Welcome to the Big Guy Podcast here on ACAST. We invite you to become members of ACAST Plus. Thank you.
Hello, thank you for joining us today. We are really glad you're here. Here's Jim, your host of Time Out with Jim. So let's get started.
Talking about borderline personality disorder, or BPD. BPD is a mental illness characterized by a long-term pattern of unstable relationships, distorted sense of self, and strong emotional reactions. Those affected can often engage in self-harm and other dangerous behavior. They may also struggle with feeling of emptiness, fear of abandonment, and detached from reality. Symptoms of BPD can be triggered by events considered normal to others. The behavior in BPD typically begins by early adulthood and occurs across a variety of situations. Substance abuse, depression, eating disorders are commonly associated with BPD. About 10% of people affected with the disorder die by suicide. The disorder is often stigmatized in both the media and the psychiatric field. The causes of BPD are unclear, but seem to involve genetic, neurological, and environmental and social factors. It occurs about 5 times more often in a person who has an effective close relative. Adverse life events appear to also play a role. BPD is typically treated with therapy such as cognitive behavior therapy, dialectical behavior therapy. DBT may reduce the risk of suicide in this disorder. Therapy for BPD can occur one-on-one or in a group, while medications cannot cure BPD. About 1.6% of people who have BPD in a given year, with some estimates as high as 6%. Women are diagnosed about 3 times as often as men. The disorder appears to become less common among older people. Up to half of those with BPD improve over a 10-year period. Those affected typically use a high amount of healthcare resources. There is an ongoing debate about the naming of the disorder, especially the suitability of the word borderline. Signs and symptoms. BPD is characterized by the following signs and symptoms. Markedly disturbed sense of identity, frantic efforts to avoid real or imagined abandonment, and extreme reactions to such splitting, black and white thinking, impulsive or reckless behaviors like spending money, unsafe sex, reckless driving, substance abuse, and binge eating. Intense or uncontrollable emotional reactions disproportionate in the event or situation. Unstable and chaotic interpersonal relationships, self-damaging behavior, distorted self-image, yep, I have that, disassociation, frequently accompanied by depression, anxiety, anger, substance abuse, or rage. Other symptoms may include feeling unsure of one's personal identity, morals, and values, having paranoid thoughts with feeling stress, depersonalization, and in moderate to severe cases, stress-induced breaks with reality or psychotic episodes. People with BPD may feel emotions with greater ease and depth and for a longer time than others do. A core characteristic of BPD is affective instability, which generally manifests as usually intense emotional responses to environmental triggers, with a slower return to a baseline emotional test. To a baseline emotional state. People with BPD are often exceptionally enthusiastic, idealistic, joyful, and loving, but may feel overwhelmed by negative emotions, experiencing intense grief instead of sadness, shame, and humiliation instead of mild embarrassment, rage instead of annoyance, and panic instead of nervousness. People with BPD are also especially sensitive to feelings of rejection, criticism, isolation, and perceived failure. Before learning other coping mechanisms, their effort to manage or escape from the very negative emotion may lead to emotional isolation, self-injury, or suicidal behavior. They are often aware of the intensity their negative emotional reactions, and since they cannot regulate them, shut them down entirely, since awareness would only cause further distress. This can be harmful since negative emotions alert people to the presence of problem of a situation and move them to address it. While people with BPD feel euphoria, they are especially prone to dysphoria, depression, and/or feelings of mental and emotional distress. In addition to intense emotions, people with BPD experience emotional lability, changeability, or fluctuation. Although the term suggests rapid changes between depression and elation, mood swings in people with BPD more frequently involve anxiety, with fluctuation between anger and anxiety, and between depression and anxiety. Interpersonal relationships. People with BPD can be very sensitive to the way others treat them by feeling intense joy and gratitude at perceived expressions of kindness, and intense sadness or anger at perceived criticism or hurtfulness. People with BPD often engage in idealization, devaluation of others, alternating between high positive regard for people and great disappointment in them. Their feelings about others often shift from admiration or love to anger or dislike after disappointment, a threat of losing someone, or a perceived loss of esteem in the eyes of someone they value. While strongly desiring intimacy, people with BPD tend toward insecure, avoidant, or ambivalent, or fearfully preoccupied attachment patterns in relationships, and often view the world as dangerous and malevolent. Like other personality disorders, BPD is linked to increased levels of chronic stress and conflict in romantic relationships, decreased satisfaction of romantic partners, abuse, and unwanted pregnancy. Impulsive behavior is common, including substance or alcohol abuse, eating in excess, unprotected sex, or indiscriminate sex with multiple partners, reckless spending, reckless driving. Impulsive behavior may also include leaving jobs or relationships, running away, and self-injury. People with BPD might do this because it gives them the feeling of immediate relief from their emotional pain, but in the long term they feel increased shame and guilt over the inevitable consequences of continuing this behavior. A cycle often begins in which people with BPD feel emotional pain, engage in impulsive behavior to relieve that pain, feel shame and guilt over the action, feel emotional pain from the shame and guilt, and then experience stronger urges to engage in impulsive behavior to relieve the new pain. As time goes on, impulsive behavior may become an automatic response to emotional pain, Self-harm and suicide. Self-harming or suicidal behavior is one of the core diagnostic criteria. Self-harm occurs in 50 to 80% of people with BPD. The most frequent method of self-harm is cutting. That's what I used to do. I used to do it like every day, multiple times a day. But now, since I've been getting help, I've been seeing a doctor, a psychiatrist, so I'm getting help with that. And so I don't do it every day now. I said the last time I done it was maybe 6 months ago. Okay, bruising, burning, head banging, or biting are not uncommon with BPD. People with BPD may feel emotional relief after cutting themselves. Yes, that is true. The lifetime risk of suicide among people with BPD is between 3% and 10%. There is evidence that men diagnosed with BPD are approximately twice as likely to die by suicide as women diagnosed with BPD. There is also evidence that a considerable percentage of men who die by suicide may have undiagnosed BPD sense of self. People with BPD tend to have trouble seeing their identity clearly. In particular, they tend to have difficulty knowing what they value, believe, prefer, and enjoy. They are often unsure about the long-term goals for relationships and jobs. This could cause people with BPD to feel empty and lost. Self-image can also change rapidly from healthy to unhealthy. The often intense emotions people with BPD experience can make it difficult for them to concentrate. They may also tend to disassociate, which can be thought of as an intense form of zoning out. Others can sometimes tell when someone with BPD is disassociating because the facial or vocal expressions may become flat or expressionless, or they may appear distracted. Disassociation often occurs in response to a painful event or something that triggers the memory of a painful event. It involves the mind automatically redirecting attention away from that event, presuming to protect against intense emotion and unwanted behavior impulses that such emotion might trigger. The mind's habit of blocking out intense painful emotions may provide temporary relief, but it can also have the side effect of blocking or blunting ordinary emotion, reducing the access of people with BPD to the information those emotions provide. Information that help guide effective decision making in daily life. As is the case with other mental disorders, the causes of BPD are complex and not fully agreed upon. Evidence suggests that BPD and post-traumatic stress disorder may be related in some way. Most researchers agree that a history of childhood trauma can be a contributing factor, but less attention has historically been paid to investigating the causal roles played by congenital brain abnormalities, genetic, neurobiological factors, and environmental factors other than trauma. Social factors include how people interact in their early development with their family, friends, and other children. Psychological factors include the individual's personality and temperament, shaped by their environment, a learned coping skills that deal with stress. These different factors together suggest that there are multiple factors that may contribute to the disorder. And we're going to stop right there for part one. Part two, we'll start with brain abnormalities please. So, and remember, materials contained on here are for informational purposes only. The content is not intended to be a substitute for professional advice, diagnosis, or treatment. Always seek the advice of your doctor or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you have a medical emergency, call your doctor or 911 immediately.
So let's get started.
Borderline personality or BPD. We're going to start off with brain abnormalities. A number of neuroimaging studies in BPD have reported findings of reduction in regions of the brain involved in the regulation of stress responses and emotions, affecting the hippocampus, the orbital frontal cortex, and the amygdala, amongst other areas. A smaller number of studies have used magnetic resonance spectroscopy to explore changes in the concentration of neurometabolites in certain brain regions of BPD patients. Looking specifically at neurometabolites, neurobiology, borderline personality disorder has previously been strongly associated with the occurrence of childhood trauma, while many psychiatric diagnoses are believed to be associated with traumatic experiences occurring during critical periods of childhood. Specific neurobiological factors have been identified within patients diagnosed with BPD. Dysregulations of the hypothalamic pituitary adrenal axis and cortisol levels have been intensively studied in individuals who have experienced childhood traumas and have been formally diagnosed with BPD. The HPA axis functions to maintain homeostasis when the body is exposed to stressors that have been found to be dysregulated among individuals with the history of child abuse. When the body is exposed to stress, the hypothalamus, specifically the paraventricular nucleus, releases peptides and corticotropin releasing factor. When these peptides travel through the body, they stimulate corticotropic cells, resulting in the release of adrenocorticotropic hormone, or ACTH. ACTH binds to the receptors of the adrenal cortex, which stimulates the release of cortisol. Intracellular glucocorticoid receptor, subtypes of mineralocorticoid receptor, and low affinity type receptor have been found to mediate the effects of cortisol on different areas of the body, while MRs have high affinity to cortisol and are highly saturated in response to stress. GRs have low affinity to cortisol and bind cortisol at high concentration when the individual is exposed to a stressor. For those with BPD who have experienced childhood trauma, there is a strong correlation between child abuse, especially child sexual abuse, and development of BPD. Many individuals with BPD report a history of abuse and neglect as young children, but causation is still debated. Patients with BPD have been found to be significantly more likely to report having been verbally, emotionally, physically, or sexually abused by caregivers of either sex. They also report a high incidence of incest and loss of caregivers in early childhood. Individuals with BPD were also likely to report having caregivers of both sexes deny the validity of their thoughts and feelings. Caregivers were also reported to have failed to provide needed protection and to have neglected the child's physical care. Parents of both sexes are typically reported to have withdrawn from the child emotionally and to have treated the child inconsistently. Additionally, women with BPD who reported a previous history of neglect by a female caregiver and abuse by a male caregiver were significantly more likely to have experienced sexual abuse by a non-caregiver. It has been suggested that children who experience chronic early maltreatment and attachment difficulties may go on to develop borderline personality disorder. Mediating and moderating factors. Executive, while high rejection sensitivity is associated with stronger symptoms of borderline personality disorder, executive function appears to mediate the relationship between rejection sensitivity and BPD. That is, a group of cognitive processes that include planning, working memory, attention, and problem solving might be the mechanism through which rejection sensitivity impacts BPD. The relationship between a person's rejection sensitivity and BPD symptoms are stronger, then executive function was lower and that the relationship was weaker. When executive function was higher, this suggests that high executive function might help protect people who have high rejection sensitivity against symptoms of BPD. Self-complexity, or considering oneself to have many different characteristics, may lessen the apparent discrepancy between an actual self and a desired self-image. Higher self-complexity may lead a person to desire more characteristics instead of a better characteristic. If there is any belief that character should have been acquired, they may be more likely to have been experienced as examples rather than considered as abstract qualities. The concept of a norm does not necessarily involve the description of the attribute that represent the norm. Cognition of the norm may only involve the understanding of being like a concrete relation and not an attribute. Thought suppression. The thought suppression of conscious attempts to avoid thinking certain thoughts mediates the relationship between emotional vulnerability, BPD symptoms. A later study found that the relationship between emotional vulnerability and BPD symptoms is not necessarily mediated by thoughtful suppression. However, this study did find that thought suppression mediates relationship between an invalidating environment and BPD symptoms. Diagnosis of borderline personality disorder is based on clinical assessment by mental health professional. The best method is to present the criteria of the disorder to a person and to ask them if they feel that these characteristics accurately describe them. Actively evolving people with BPD is determining their diagnosis can help them become more willing to accept it. Some doctors prefer not to tell people with BPD what their diagnosis is. Either from concern about the stigma attached to this condition or because BPD used to be considered untreatable. It is usually helpful for the person with BPD to know their diagnosis. This helps them know what that others have had similar experiences and can point them toward effective treatment. Family members. People with BPD are prone to feeling angry at members of the family and alienated from them. On their part, family members often feel angry and helpless at how their BPD family members relate to them. Parents of adults with BPD are often both over-involved and under-involved in family interactions. In romantic relationships, BPD is linked to increased levels of chronic stress and conflict, decreased satisfaction of romantic partners, abuse, unwanted pregnancy. However, these links may apply to personality disorders in general. Adolescence. Onset of symptoms typically occurs during adolescence or young adulthood. Those symptoms suggest this disorder can sometimes be observed in children. Symptoms among adolescents that predict the development of BPD in adulthood may include problems with body image, extreme sensitivity to rejection, behavior problems, non-suicidal self-injury, attempts to find exclusive relationship, and severe shame. Many adolescents experience these symptoms without going on to develop BPD, but those who experience them are 3 times as likely as their peers to develop BPD. They are also more likely to develop other forms of long-term social disability. BPD is recognized as a valid and stable diagnosis during adolescence. The diagnosis of BPD, also described as personality disorder, borderline pattern qualifier in adolescence, is supported in recent updates. Accordingly, national treatment guidelines recommend the diagnosis and treatment of BPD among adolescents in many countries, including Australia, the United Kingdom, Spain, and Switzerland. A BPD diagnosis in adolescence might predict that the disorder will continue into adulthood. Among individuals diagnosed with BPD during adolescence, there appears to be one group in which the disorder remains stable over time, and another group in which the individuals move in and out of the diagnosis. Earlier diagnosis may be helpful in creating a more effective treatment plan for the adolescent. Family therapy is considered a helpful component of treatment for adolescents with BPD. That's going to be it for part 2, and next time we will start out with the differential diagnosis. Remember, as always, materials contained on here are for informational purposes only. The content is not intended to be a substitute. The content is not intended to be a substitute for professional advice, diagnosis, or treatment. Always seek the advice of your doctor or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. This will be the third and last part, borderline disability disorder. We're going to start out with differential diagnosis. Lifetime co-occurring conditions are common in BPD. Compared to those diagnosed with other personality disorders, people with BPD showed a higher rate of also meeting criteria for mood disorders, including major depression and bipolar disorder, anxiety disorders, including panic disorder, social anxiety disorder, and post-traumatic stress disorder, PTSD. Other personality disorders, including schizotypal, antisocial, and dependent personality disorder, substance abuse, eating disorders, ADHD, somatic symptom disorders, formerly known as a somatoform disorders, a category of mental disorders included in a number of diagnostic schemes of mental health, mental illness, and dissociative disorders. A diagnosis of a personality disorder cannot be made during an untreated mood episode unless the lifetime history supports the presence of a personality disorder. They are marked sex differences in the types of comorbid conditions. A person with BPD is likely to have a higher percentage of males with BPD meet criteria for substance abuse disorders with a higher percentage, while a higher percentage of females with BPD meet criteria for PTSD and eating disorders. In one study, 38% of participants with BPD meet the criteria for a diagnosis of ADHD. And another study, 6 of 41 people, 15%, meet the criteria for an autism spectrum disorder. Mood disorders. Many people with borderline personality disorders also have mood disorders, such as major depressive disorder or bipolar disorder. Some characteristics of BPD are similar to those of mood disorders. They can complicate the diagnosis. It is especially common for people to be misdiagnosed with bipolar disorder when they have borderline personality disorder or vice versa. For someone with bipolar, behavior suggestive of BPD might appear while experiencing an episode of major depression or mania, only to disappear once mood has stabilized. For this reason, it's ideal to wait until mood has stabilized before attempting to make a diagnosis. At face value, the effective lability of BPD and the rapid mood cycling of bipolar disorders can seem very similar. It can be difficult even for experienced clinicians if they are unfamiliar with BPD to differentiate between the mood swings of those two conditions. However, there are some clear differences. First, the mood swings of BPD and bipolar disorder tend to have different durations. In some people with bipolar, episodes of depression or mania last for at least 2 weeks at a time, which is much longer than moods last in people with BPD. Even among those who experience bipolar disorder with more rapid mood shifts, their moods usually last for days, while the moods of people with BPD can change in minutes or hours. So while euphoria and impulsivity in someone with BPD might resemble a manic episode, the experience shall be too brief to qualify as a manic disorder. The moods of bipolar do not respond to changes in the environment, while the moods of BPD do respond to changes in the environment. That is, a positive event will not lift the depressed mood of someone with BPD. An undesirable event will not dampen the euphoria caused by bipolar disorder, but an undesirable event will dampen the euphoria of someone with borderline personality disorder. When people with BPD experience euphoria, it is usually without the racing thoughts and decreased needs for sleep that are typical of hypomania. though later, because of the two conditions have a number of similar symptoms. BPD was once considered to be a mild form of bipolar, or to exist on the bipolar spectrum. However, this will require that the underlying mechanism causing these symptoms to be the same for both conditions. Differences in family history, longitudinal course, and responses to treatment suggest that this is not the case. Researchers have found only a modest association between bipolar disorder and BPD, with a strong spectrum relationship with BPD. Bipolar extremely unlikely. Pre-menstrual dysphoric disorder, Pmdd, it occurs in 2 to 8% of women. Symptoms begin during the luteal phase of their cycle and end during menstruation. Symptoms may include marked mood swings, irritability, depressed mood, feeling hopeless or suicidal, a subjective sense of being overwhelmed or out of control, anxiety, binge eating, difficulty concentrating, and substantial impairment of interpersonal relationships. People with Pmdd typically begin to experience symptoms in their early 20s, although many do not seek treatment until they are in the early 30s. Although some of the symptoms of Pmdd and Bpd are similar, they are different disorders. They are distinguishable by the timing and duration of symptoms, which are marked differently. The symptoms of Pmdd occur only during the luteal phase of the menstrual cycle, whereas Bpd symptoms occur persistently at all stages of the menstrual cycle. In addition, the symptoms of Pmdd do not include impulsive comorbid access to disorders. About 3/4 of people diagnosed with Bpd also meet the criteria for another access to personality disorder at some point in their lives. The cluster A disorder, paranoid schizoid, and schizotypal are broadly the most common. The cluster as a whole affects about half, the schizotypal alone affecting 1/3. Bpd is itself a cluster B disorder. The other cluster B disorders, antisocial, histrionic, narcissistic, similarly affect about half of Bpd patients' lifetime incidence, with again narcissistic affecting 1/3 or more. Cluster C, avoidant, dependent, obsessive, compulsive, show the least overlap, slightly under 1/3. Psychotherapy is the primary treatment for borderline personality disorder. Treatment should be based on needs of individuals rather than upon the general diagnosis of Bpd. Medications are useful in treating comorbid disorders such as depression, anxiety. Short-term hospitalization has not been found to be more effective than community care for improving outcomes or long-term prevention or suicidal behavior in those with Bpd. Long-term psychotherapy is currently the treatment of choice for Bpd, while psychotherapy, in particular dialectical behavior therapy and psychodynamic approaches, is effective. The effects are slow. Many people have to put in years of work to be effective. More rigorous treatments are not substantially better than less rigorous treatment. Long-term therapy of any kind, including schema-focused therapy, is better than no treatment, especially in reducing urges to self-injure. Transference-focused therapy aims to break away from the absolute thinking. In this, it gets the people to articulate the social interpretations and their emotions in order to turn their views into less rigid categories. A therapist addresses the individual's feeling and goes over situations, real or realistic, that could happen, as well as how to approach them. Cognitive behavior therapy, CBT, is also a type of psychotherapy used for treatment of BPD. This type of therapy relies on changing people's behaviors and beliefs by identifying problems from the disorder. CBT is known to reduce some anxiety and mood symptoms, as well as reduce suicidal thoughts and self-harming behavior. Medications. The typical antipsychotics studied in relation to BPD, haloperidol may reduce anger, and fluphenazole may reduce the likelihood of suicidal behavior. Among the atypical antipsychotics, one trial found that aripiprazole may reduce interpersonal problems and impulsivity. Olanzapine, as well as ketapine, may decrease affective instability, anger, psychotic paranoid syndromes, and anxiety. But a placebo has a greater benefit on suicidal ideation because of weak evidence and the potential for serious side effects for some of these medications. The National Institute of Health and Clinical Excellence in the UK recommends drug treatment should not be used specifically for borderline personality disorders or for the individual symptoms or behavior associated with disorder. However, drug treatment may be considered in the overall treatment of comorbid conditions with borderline personality disorder who do not have a diagnosed comorbid mental or physical illness and who are currently being prescribed drugs with the aim of reducing and stop unnecessary drugs. With treatment, majority of people with BPD can find relief from distressing symptoms and achieve remission, defined as a consistent relief from symptoms for at least 2 years. Patient personality can play an important role during the therapeutic process, leading to better clinical outcomes. Recent research has shown that BPD patients undergoing dialectical behavior therapy exhibit better clinical outcomes, correlated with high levels of the trait of agreeableness in the patient, compared to patients at either low in agreeableness or not being treated with DPT. This association was mediated through the strength of a working alliance between patient and therapist. That is, more agreeable patients develop stronger working alliances with the therapist, which in turn led to better clinical outcomes. In addition to recovering from distressing symptoms, people with BPD also achieve high levels of psychosocial functioning. 56% of participants have had good function in work and social environment, compared to 26% that were first diagnosed. Vocational achievement was generally more limited, even compared to those with other personality disorders. However, those first symptoms had remitted were significantly more likely to have good relationship with the romantic partner, or at least one parent, good performance at work or school, a sustained work and school history, and good psychosocial functioning overall. And that'll be it for part 3 and final episode. And remember, Materials contained on here are for informational purposes only. The content is not intended to be a substitute for professional advice, diagnosis, or treatment. Always seek the advice of your doctor or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately.
If this episode touched you in any way, please share it with your friends and family, and please consider donating to anchor.fm/timeoutwithjim and help keep our podcast going. Thank you for listening, and until next time, God bless you.
Thank you for taking your time out to give us a listen. And remember, become a member of ACAST Plus. God bless.